Go. So Major Toupin, thank you so much for joining us this morning. You've prepared this really exciting acute periodontal conditions during our coronavirus. And when you prepped this, it was about a month and a half ago. And here we are still applicable. So please share with us.
Okay. Good morning, Ashley. I'm really happy to be here with you and everyone else. Yeah, it's been actually a bit more than I actually prepared that topic in March. So it was really at the beginning of COVID. So I thought it could be interesting to discuss about how to deal with acute periodontal conditions during COVID. So here I am today to finally present it to you guys. So I don't have like cool videos like Ashley would have to show you today, but I do have very nice pictures of bacteria and viruses, as you can see in the background of the screen. This is a picture of, well, it's electronic transmission microscope image of COVID, or the SARS-CoV-2 virus, and you can probably recognize it from all the ones you've seen in the news. This has little spikes on the surface, so this is why we call coronavirus, the name comes from crown. So that's always something I find really cool, and that's probably why I'm a periodontist. I like to see those electronic images because it's easier to understand how they work. As periodontists, we learn a lot about virulence factors and properties of bacteria. So I'm not going to talk today about COVID because I haven't studied it, but we're going to discuss about very neat stuff about PERIO, because PERIO is I think a very interesting topic. So also, another reason why I like PERIO, if I can say, is that in PERIO we develop a long-term relationship with our patients, and I certainly miss it during COVID right now, and cannot wait to go back in a clinic and just do my regular PERIO stuff along with my teammates and the hygienists. I think this.
No one brings gifts to somebody who does root canals. It's always the periodontist who gets like these crazy gifts at Christmas time, and prosthodontist Major Nicholas, I don't know if he got gifts, but I'll tell you.
Yeah, I know that.
Bill used to get gifts all the time. So yes,
well,
periodontist.
I think that honestly, Ashley, the gift goes to the prosthodontist, because the prosthodontist make the teeth nice. No patient is really excited to come for surgeries, for implants or perio surgeries. They do, however, I think appreciate the service we offer, because we really know them well, and we get to know what type of car they drive and their habits and why they smoke, why they stopped. And I think we do make a difference. So that's very neat in perio. But yeah, the prosthodontist gets a lot of gifts when they get all those nice veneers or those nice crowns. But anyway, that's another topic. Cannot wait to work with my friends prosthodontist and EGD, who can refer all those endo-perio lesions to us and other stuff. Another thing I want to say about our perio patients during COVID, and this is just me speaking as a periodontist in Ottawa, but I hope we can think of a way when we cancel appointments to get in touch with our patients and remind them about the importance of having good oral health during this time, because it's going to make a big difference, because we'll be very busy when we get back to normal. As you know, Ashley, our periodontist, the patient that have periodontitis are at really high risk of having recurrence of disease if they don't get their maintenance appointment. So anyway, we hope to be able to see them soon, but it's important to do that when it's going to be safe for us and also be safe for our patients. Anyway, that's not the topic of the presentation today. So next the agenda for today, if I can do that right here. So what I'll talk, I'll do quick updates during COVID and talk about the reference I've used for this presentation. We're going to talk about acute periodontal diseases. In perio, in general, it's chronic, but there is, however, a couple of conditions that you really need to take care that are acute, such as perio abscesses. Perio abscesses, we're going to talk about it very soon. It's really common in emergencies. We're going to talk also about urgent post-surgical care. Oh, why is it going this way? And I'm going to show very cool clinical cases. Initially, in March, I was really worried about the post-surgical care of all the perio surgeries I did and my colleagues did in private practice as well. This is not really more a big emergency now, but it's an interesting topic to get back to when our clinicians will be back and will be starting again perio surgeries. There's also an inclusion in this about an aide-mémoire for sutures, which sutures are resorbable or non-resorbable, and also for pharmacotherapy for how to deal with infection after perio surgeries, as well as all the other types. So it's included in this, and it's also included in another document that I'll show shortly. So this presentation should last roughly about between 50-60 minutes, and there will be a French presentation also, as well that we'll record later on. Okay, so here are my special thanks to Ashley, Major Mark, who's our RCDC webinar master, who has done, you've done an incredible work and constant support during COVID. I think it's very important for all clinicians to be able to relate to clinical stuff. So thanks a lot, Ash. Also a big thanks to Sebastian Dusty, who's our perio practice leader. When I brought him that idea about doing this document on how to deal with urgent perio stuff, he was really open and helped me a lot and reviewed the document that we did together. And I want to say a big thank to Elise Grenier, who's a periodontist in Valcartier, who helped me develop the French version of this presentation. Okay, so now let's talk about management of acute periodontal conditions during COVID. This document was released in April. All this presentation, essentially, you can find it in that document. The document is pretty dense, but all the information is there. Keep in mind that this was done in April, so there are some things that might not be as current as it was in April, but most of it are still really, really good. Actually, I don't think anything is not accurate anymore, but there's some dates as well under references that I looked on the website, so keep that in mind when you read this. So yes, perio abscesses can represent up to 10% of all dental emergencies, so that's a big one that we're going to cover now. I want to also outline the RCDC Communiqué. There's a task force who's doing tons of lit review. We have our perio practice leader who's a member of this. I think it's very important, especially those points from this communiqué here. The use of antibiotic and analgesics is okay, but it's for acute and urgent dental concerns. And long-term use of antibiotics and analgesics can lead to a tons of problems. I find that here, this point about clinical presentation will require clinical intervention beyond antibiotics and analgesics is a big, big point for you guys doing perio stuff, but also for perio abscesses. It's not the only way that we deal with emergencies. It was okay at the beginning of COVID when we didn't really know how to wear the PPE and how to deal with that. But now that the acute phase of COVID, if we can say, is past, and we know more about how to deal with this situation, we need to think beyond just going for antibiotics and analgesics. The other thing that we really must outline is this here, clinical judgments, and evaluate each case. There's no case that's exactly the same. So what I'll give you today is a tool, but you really need to use your clinical judgment, and that's not only during COVID, that's always. Keep all treatment options in mind, because at some point, if we do an extraction and we don't care about the bone anymore, and then a year from now we want to place an implant, that's going to be a nightmare for the periodontist or the oral surgeons who wants to place it. So it's really important to keep your clinical judgment and try to take the best decision for that specific case.
Yeah, you bring up a really good point, because right now we're seeing that with endo, that the first round of analgesics and antibiotics are not now we've got to do something about it. But also the whole point of what we're doing here is really the community, and for clinicians to be able to contact you yourself and the other periodontists directly if they do have those cases, any problems. So they see your face, they hear you talking, and like, wow, I've got this case in my det in, I don't know, Trenton or wherever, there's no periodontist that's open, they can contact you and get your opinion about it.
Yeah, the phone, and that's what we keep telling people always on the PERIO course, or as we do mentorship, we're just a phone call away. I'd rather have someone call me than getting a case, and I unfortunately get cases that, we could have dealt with a year or 2 years ago from now. And then we try to do something, but we're really in the compromise. So it's so much easier when you don't know to just call, and we're going to give you guidance. And that's not only for periodontists, that's for all the specialties. I once in a while go and see my best friend, the oral surgeon, when I'm not sure about when extraction, that's very tough. And it's okay to put our ego aside and go and see our colleagues. The prosthodontist is my best friend because I'm placing implants, but I really want to make sure I place it exactly where he wants it. So that's why we're a big team. Even if you're not in a specialty center, you can call us. We're always there, and we're always happy to call you back, because we all love talking about clinical stuff. So don't hesitate to call if you're a young captain, you're not sure, first time you do something, and you know what? I'd rather have someone who calls and asks than someone who thinks he knows it all. Okay. Now, acute periodontal diseases. What are they? Well, they're rapid onsets of clinical conditions that involve in the periodontium or the other structure, and they're characterized here by pain, tissue destruction, and infection. So that's why it's important. As we let the perio abscess or another condition, acute perio condition, go on, there's tissue destruction that keeps going on, and it can be very fast, and it deals also with infection and pain. So that's why it's acute periodontal conditions. So what are those? Perio abscesses, endo-periodontal lesions, necrotizing periodontal diseases. So those are the big trees. There's also that primary herpetic gingival stomatitis. It's not a perio disease by itself, but it touches the periodontium and it's acute. So that's why I included it here. So as I said, rapid destructions may occur, and the diagnosis, prompt diagnosis is important, and treatment as well. I just want to say that all this presentation is based on one big paper that was done about the new perio classification. So all the terms are the current one. If you've got any questions about this presentation as well, you can just send me an email after, and I'll be happy to answer. Okay, so perio abscesses is a big one. So here, Ashley, do you know what this is?
That looks like the moon.
Yeah, well, it's really cool, eh? I would love to have that in my living room, but it's Porphyro mornes gingivalis.
That was my second guess.
So that's the big one in perio, but there's a lot of different bacteria that we deal with, but this one is the big one. Anyway, so perio abscesses. It's very important for a perio abscess or for any abscess to find the cause, what's the etiology, because in the periodontium there's so many abscesses that can touch it. You can have just an endo lesion or a pulp necrosis. You can have periodontal infection, so periodontal abscess. You can have a pericoronitis. It can come from a trauma. It can be a post-op surgery infection, abscess, or you can just have something as example for food impacted in the periodontium. So anytime you deal with any infection or abscess in the periodontium, you really want to find what's the etiology. And finding the etiology will tell you how to deal with it. It's important to remember that all abscesses touching the periodontium, they're associated with enlargements of periodontal ligament. Yeah. So what's a perio abscess? A perio abscess is the accumulation of pus located within the gingival wall here in the periodontal pocket, where there's periodontal breakdown that's happening. So there's the pathophysiology is that there's bacterial invasion of the soft tissue happening. The bacteria that are mostly found in the perio abscess is Porphyromonas gingivalis, Prevotella intermedia, but there's tons of different bacteria that can be found there. Then there's an inflammatory process that will happen. So that soup of all those PMNs and cytokines, and you might remember your immunology, but that's what's happening there. And then that leads to destructions of connective tissue, and then an encapsulation of that bacterial infection that cannot be released. And then there's production of pus. So that's all what you're seeing here. I won't do too much etiology stuff because I'm very passionate about this, but you might not find it as interesting.
That's amazing.
Importance of management. Well, we already said it's very common. So 7 to 10% of all dental emergencies are perio abscesses, and it's very important to know that most common for periodontitis patients. So, if you've got a periodontitis patient who is not treated, let's say, for example, during COVID, you might be seeing at your desk a lot of perio abscesses. So there's a clear difference between patients with periodontitis who are treated for perio disease versus those who are not treated. And you can see those percentage here. So a perio patient that's seeing the hygienist every 3 months, and that the periodontitis is not active anymore, and now is going to a more stable periodontal condition, has less chances of doing perio abscesses. But someone who's untreated, is missing all his maintenance appointment, that is at higher risk of perio abscesses. So perio abscesses will destruct the tissue very quickly and will have a big impact of the prognostic of the tooth, and it's going to eventually lead to tooth loss if it's not treated, and that can happen very quickly. And it's very important to know as well that perio abscesses, there's systemic dissemination of that infection that have been reported in the literature, so we don't want to leave that. Here is a table where we see the etiologic factors with regards to perio abscesses. So you've got here perio patients versus non-perio patient. So for perio patient, you've got all those all those different things here. So untreated periodontitis. You can have also sometimes a perioabscess after a scaling. It happens when the hygienist or the dentist is doing a root debridement, and then there's a piece of calculus that stays there that is dislodged, and then on top there's a healing of that pocket, and then it closes. But it can do happen that there's a perioabscess there. You can also have a post-surgical perioabscess, or let's say you decide that, oh, there's a patient with big, like what we would call in the past aggressive periodontitis, but you don't do any root debridement, you just treat with very heavy antibiotics, but you don't do any debridement. Well, all those pockets can close, and then you can have to deal with multiple perioabscesses. You can also have perioabscesses in non-periodontitis patients. So if there's something that's impacted, the typical popcorn that will stick in the gingival tissue, or dental floss, or orthodontic elastic can lead to a perioabscess. Those are very easy to treat. You just need to remove the cause. You can have other like orthodontic factors. You can have also gingival overgrowth, and because the tissue has all that overgrowth, it's very difficult to clean properly, and then there's something that can stay stuck there, so that can happen too. The other big one is if there's alteration of the root surface. So if there's a local factor, for example, like some dents invaginatus, or cemented tear, or enamel pearl, or just developmental grooves on the root, well, that's a place where all the bacteria and all it's going to create a little microenvironment, and it's really more prone for perioabscesses. Also, if there's a perforation on the root due to previous treatment, or a severe root damage for a fracture or external resorption, it can lead to perioabscesses. Any questions so far, Ashley?
No, I was just thinking about, I remember seeing a patient who was, I can't remember who it was, and it was, she was being treated for periodontal disease, and she was very aggressive, very excited with the Christmas tree. Why I've been off dentistry for like 3
months. Yeah, the interdental brushes.
Yeah, and she had one of those things jammed in there. Oh. And it'd been like probably a week, and then we find, she's like, wow, this is killing me. I pick it out of there. Oh, it was private practice. Actually, it was like an 80-year-old, 75-year-old lady, and like, wow, because she was referred for endo for that. And then clinical exam, like, wow, I think you got this in there. And I'm like, man, you did an incredible job of cleaning your teeth, and you also broke a piece off in there too. So
probably very good perio patient, because she listens to the narration, but just a bit too much.
I'm telling you,
those patients either like they do it a lot, or they do it once in a while, or those that overdo it. And our typical like overdoers are often all the people who need grafts because they're the aggressive brushers, but that's another topic. Okay, let's get back to perioabscesses here. So what are the clinical features? Well, the presence of a novoid elevation in the tissue alongside the root. I took some pictures. Unfortunately, I see a lot of perioabscesses, but I never take the time to pick my camera to take that pictures of when I press to see the pus. So I had to use some textbook pictures here. But yes, that's what you can see. Suppuration and probing is a big clinical feature. What are the symptoms? In general, sometimes it can be very light. So they'll say, well, when I close, it's a bit sensitive. It's often very tender on the gingiva. You can see some swelling. Sometimes there is none. When it's very small. Sensitivity of percussion is a big one. Increased tooth mobility, yes, for patients who have already perio disease. It's not because suddenly there's tooth mobility that the tooth needs to be out, but just because when you treat the cause, the tooth mobility will probably reduce after, unless you waited too long. Bleeding on probing will be a big one. It's usually found with the site with deep periodontal pocket, and yeah, extraoral findings are really rare, but it's possible. Okay, the radiographic examination. This is what you can see. This really looks also like an endo-periodontal lesion. We're going to talk about that soon, but enlargements of the PDL is something that we typically see on the radiographs. Depending if it's a patient with perio disease or not, you're going to see a lot of bone loss or not. So it's going to help you with the prognosis and the treatment that you'll decide for that patient. So the treatment is really try to reverse that accused phase by removing the cause. So remember about the etiology, that's very important here. Surgical root planing or root debridement, you want to establish a drainage and remove the microbial deposits. In more acute situation where it's really a localized infection, you might need to do incision and drainage. Use of systemic antibiotics. In general, I use it. I find it works well, and I'll show you what I use. Surgical access may be required for incision and drainage, and you need to do a follow-up. If after 24 hours everything is good, then you don't need to do further treatment. But if in 24 hours there's still some symptoms, it's important to follow up and see what's going on. What are the key points during COVID? Well, everything I said applies. You want to be, during COVID, you should do more screening over the phone. Root debridement, use your hand instruments. Normally I would use Cavitron to do the root debridement along with my hand instruments. But here, because we want to minimize aerosol, try to avoid Cavitron or piezo. You can as well use gentle irrigation. I like to irrigate gently with chlorhexidine as I'm doing my root debridement. Antibiotics for acute case and for patient at risk, especially for patients who are diabetics or smokers, because it's not going to resolve by itself. During COVID, you really want to make sure that you take care of that for acute cases. If the tooth has a very poor periodontal prognosis, you see the radiograph, it has more than 50% of bone loss. And there is no, like, you don't see any issues with the removing that tooth at short term, then, and there is a furcation involvement, mobility 2 or 3, then I would proceed to tooth extractions using a traumatic tooth extraction principles as much as you can, minimizing as well aerosol generating procedures. For myself, I would probably do a bone graft at the same time, but that's something that is not the topic here. I would then do a regular follow-up because you really want to make sure during COVID that resolutions of sign of infections are taken care of and reassess the area if needed, and consult the periodontist for guidance if you're unsure about this. This is what I've prescribed for perio abscesses. So amoxicillin, I give a loading dose of 1 gram, followed by a maintenance dose of 500 milligrams for 3 days. So it's very short in terms of the antibiotics regimen that we need to give for abscesses, but that's really what's has been recommended in all the perio world. You've got as well here if there's any allergies. But as I said earlier, at the end and in the document we sent, there's a big end memoir with all those medications.
So I just have a question here because it's very interesting seeing that it's 3 days versus the usual 7 to 10.
Yeah.
So what, you know, I've been out for about ridiculously 20 years now.
Yeah.
And things have obviously changed. So how long is it, you know, why does PERIO go with for 3 days for this type of situation?
Because we don't only do this, we do also the root debridement. So you're treating the cause. The amoxicillin, honestly, I remembered my pharmacotherapy lecture in PERIO, and the guy who came to talk to antibiotics, and really the 7 to 10 days is a bit arbitrary in general. But depending on the condition, because here in PERIO abscesses, you're treating the cause, I would certainly, for a patient who's diabetic or smoker, give that, or who has like severe PERIO, I would give that for sure. For a patient who just have, let's say, floss or food stuck, I wouldn't give anything. So it's a bit using your judgment, but why the 3 days? I think it's because we're treating the cause, but honestly, I cannot say much more about that. The amoxicillin in general for a post-op infection, I give it for 7 to 10 days because it's a post-op infection. Yes, you may be able to treat the cause, but you want to have a longer action because the PERIO abscess responds really well to root debridement. That's why I think three days is sufficient, but the loading dose is really effective. But for a patient who's diabetic, for sure, I'm going to prescribe that.
All right, cool. Thanks.
Sure if it answers your questions.
Yep.
That's it? Good?
Yeah, absolutely. Sorry, there's a delay in this thing. Yeah, absolutely. It is.
Cool. Okay. What are the differential diagnosis for PERIO abscesses? Well, they're outlined here, so remember to think about other stuff. You can have also some cystic lesion, like a lateral periapical cyst. You can have other lesions, so just don't go all like from the beginning, say, oh, for sure it's a PERIO abscess. Make sure you remember to think about etiology and remember those differential diagnosis. Big one here, because it can be difficult to differentiate between endo and perio. So I've outlined it, this. I found that although this comes from the reference documents, but I think it shows really well. Whenever you see that, do a test. You want to do vitality tests. People are surprised often when they come into my room how often I'll ask for emergency treatment to do vitality tests, because I really want to make sure that I don't deal with something that's endo versus something that's perio. So the differences for perio abscesses, often you'll see a periodontal pocket. The radiograph might be helpful to show what's the defect, where does it come from, if there's angular bone loss, is there a furcation involvement. The test of the vitality test will help you a lot. Normally for perio abscess, swelling will include the gingival tissue, and sometimes we'll see a fistula. The pain is usually more dull, more localized, and sensitivity to percussion may or may not be present. For pulpal abscess or from an endo cause, often you'll see a large restoration. You may not have any periodontal pocket or just a very narrow defect. The test will show non-vital pulp or will be different. Swelling is often localized more at the apex with fistulous tract. Pain is often more severe and difficult to localize, and there's sensitivity to percussion. So I think this is really helpful for clinicians to try to differentiate, because sometimes it can be very tough. And this leads us to our next topic about the endo-perio lesions. Because, do you like this picture, Ashley?
Yes, I recognize what that is. That is not the moon. That's something filled with something. Or let's just like, well, it's roots anyways.
It's roots, yeah. I found that cool. But I don't know much about what's the bacteriology for endo lesions. My endodontist and colleagues like AGD would help me more with that. Okay, so endo-periodontal lesions. There are some clinical conditions that will involve both the pulp and the periodontal tissues. They can be either acute or chronic. In the previous perio classification, they were called the combined perio-endo lesions. This comes from the endodontist who gave us the course about perio and endo lesions. This is another system that they use in endo. I'm not sure now what's the latest system, but that's a system used by Simon in 1972. I really like it because it shows that you can have either a primary endo lesions, then you can have an endo lesions with secondary perio involvement. You can have a primary perio lesions or a primary perio lesions with secondary endo involvement, or just a true combined lesions. So you can have tons of causes that can lead to a perio-endo lesions, but it's very important to see is that just a basic endo lesions, a basic perio lesions, or is something that's combined. Knowing which one comes from which is not that important, because what we really want to do is treat the situation as it is when the patient presents. So for an endo-perio lesions classification, that comes from the latest perio classification, I find that really good because they make the difference if there's root damage versus no root damage. We see that all the time, and I'm sure you see that as you do your phase ones for all the general dentists, and you're doing probing around, and then whoops, what's that pink stuff? The external root resorption. That's something that you need to deal with. There's also root fractures and cracking, root canal or pulp chamber perforation. So that comes with all endo-perio lesions with root damage. Endo-perio lesions without root damage. Oh, sorry, my husband is bringing some stuff for the kids, the homeschooling stuff, you know, really exciting. Okay, endo-perio lesions without damage. So that's something else that you want to look at. Then what it shows here is depending of how the defect is, the periodontal defect is, it can be either a grade 1, 2, or 3. It's either going to be easier or not easier to treat. That's a bit complex, I find, but I like the fact that in the latest classification, they made a distinction between with or without root damage. What are the risk factors? Well, if a patient has a severe periodontitis, it's more at risk of having eventually an endo-perio lesion because, let's say, for example, there's a furcation involvement, then it can lead to an endo issue coming from that little accessory canals coming from the furcation. Also, if there's trauma, it's associated with fracture that needs to be taken care of. Some iatrogenic events, for example, a perforation can lead to some perio-endo lesions, or if there's local anatomic factors. It's important to remember those palatal grooves, they happen very often on the lateral, the maxillary laterals, if there's furcation involvement as well. Okay, so let's show some pictures here. So clinical features of endo-perio lesions. If a patient has periodontitis, it's often slow and chronic. It's going to progress without any evident symptoms. For most common, you'll see very deep periodontal pockets reaching or close to the apex, and negative and alter response to vitality pulp test. So the first thing to do for all endo-perio lesions is do the vitality test, because when you do those, then you can treat the endo first and then treat the perio, because sometimes it looks like the prognosis of that tooth is awful from a periodontal point of view, but it's really just as soon as you're going to do the endo treatment, the periodontal loss can, the bone can fill and it can really heal well. Other signs and symptoms: bone resorptions in the apical and furcation region, spontaneous pain or pain on palpation and percussion, purulent exudate tooth mobility, sinus tract, crown and gingival color alterations. That's what you'll see as signs and symptoms. That's one of my patients here that I saw a couple of years ago. So you need, when you see a patient, to do the history of the lesion, if it's available, because sometimes the patient won't know much, but that's the beauty of being in the military. We in general are able to have a good history of lesions. So you want to do vitality tests, a comprehensive perio exam. So you want to do some probing, but not only on that tooth. You want to see if there's perio somewhere else. So I would do like a good probing of all the sextant, and also I would do like a PSR everywhere else just to see if it's a perio patient or not. Looking at the radiograph is very important, but not only that tooth, looking at the overall radiographs to see if it's a perio patient. Then you want to see, like, look carefully at the root anatomy and try to see if there's a fracture, a perforation, or anything else. The diagnosis should be based on the present disease status. So it's not really that important to know whatever happened 10 years ago. It can help you for having a correct diagnosis, but it should be really what is the patient presenting with. So Ashley, this case here, can you tell me what you think it is?
Well, honestly, I was looking at that, and it could be I'm seeing an endo thing. I'm not really seeing a perio thing but that's my experience. So, I mean, we've got
okay, I'm going to give you a bit more history here. So this tooth here is support of PUD.
Yeah.
The patient has a lot of erosion, not only erosion, attrition, but you see like the wear on his teeth is very severe. Yeah. So that's the terminal tooth of his PUD, and he has here a very deep periodontal pocket going up to probably the apex. So I don't remember exactly number of millimeters, but he's not really like complaining much of any pain. But this is, I think, there was mobility one of that tooth, which is very common for a tooth that's under a PUD to have some mobility, especially if it's the terminal tooth. Yeah, so go on now.
Well, I mean, it's got a CASPO score, so that's the first thing. Then we've got pretty deficient endo, and likely that looks like a 1-4 if I see that correctly. Like, we're missing a canine, so it's probably 2 canals in that. So I'm going to assume that it's either cracked or we're just missing, it needs to be refreshed on the endo, but then you got to go get that CASPO score out of there. So I don't know, a cone beam probably would help, and then a bigger picture, sort of that the strategic tooth, kind of like where's the sinus and what is the overall plan if it is the terminal tooth, right?
Yeah. Any other thing that you think you could do there to help you with your diagnosis?
Well, I mean, we've got our vitality test, comprehensive perio exam. I mean, we could trace it. Would be.
There was no fistula there.
I feel like I'm doing my boards here, so.
That's why I love interacting with the noses.
I don't know where we're. I don't know. Other than a clinical exam and all the other things I normally do.
Okay, well, it's a good thing. I didn't do any CBCT here. I'll show you after what I did. So what would be your differential diagnosis here?
Oh, differential diagnosis. I mean, it could be. Oh, you really put me on the spot here. Thank you. I appreciate that.
Well, it's
Well,
good, you know?
my initial one goes to sort of missed canal anatomy. That's the first one.
Okay,
Second is a root fracture.
okay.
Third is lateral periodontal cyst. But usually when I see this stuff in advance, all the other stuff, I kind of go towards something wrong with the endo,
Yeah.
something missed.
Oh,
Or
that's pretty good. Well, you could say like here, oh, I think it's an endo-periodontal lesion. And then you really need to look into like all this, what you did, like vitality tests, perio exams and all that stuff. But we're going to continue and I'll show you what else you can do to really try to define what's your diagnosis a bit more. If you don't have access quickly to a CBCT, which is,
well, I think the purpose of, as I say, CBCT, I mean, we're not going to be getting those, I don't think,
yeah.
frequently right now. So we kind of have to go old school.
Mm-hmm. Sometimes it's good to send it anyway to have a better idea, but sometimes there's an easy way to try to confirm your diagnosis. But I'll lead you to the next, and then we'll show you what I did. So treatment options depending on the tooth prognosis, etiology. If it's iatrogenic or trauma, it's important to consider the restorability of the tooth. If it's a perio prognosis is favorable or questionable, consider doing the endo treatment first, and it's always the case. Then, that's what I was trying to get you at. Explorative surgery is a good one to try to, when you think that there's something going on, and you said fracture in your diagnosis, I would go for explorative surgery. And when I talk to my patients, and I always tell them, okay, I think here we've got either this, this, or this. Those are our options. If I clearly see that vitality test is negative, there's some issues with the pulp, I send them for endo or to my best friend who do like the comprehensive dentist who do the endo. If it's not the case, and I'm unsure and I think about a root fracture, then I talk to them about explorative surgery. And the explorative surgery, I tell them, I'm going to do a mini flap just to see the root. And if I see that there's a line that's fractured, then we know that we need to remove it. And then I already do a consent forms for extraction and rich preservation. That's how I deal with it. But I also tell them that, you know, sometimes we open up that flap and we don't see any issues and the pulp is good. So sometimes there's just a big bone defect there that, and then I can do a root, a regenerative therapy with bone graft to really deal with that localized bone defect. But I really tried to find what was the cause first. And then if I see that during the explorative surgery, the root is fractured or the tooth is really hopeless due to very poor periodontal support, I'll do the extraction. So that's the tooth in question. So I did that mini flap. So you see there is like just a circular incision here. And then I use the methylene blue, who's my best friend too. And then you see that little crack here. It's difficult to see on that screen, but this crack was going down. So I did the extraction and there you go. So you see that crack here. And I on purpose left a lesion that came up with. So you can see that it was just a root fracture. But I think that your idea about doing a CBCT might have been a good idea, especially if we would have them in our clinic. But I was pretty sure here that it was a root fracture because the bone, the defect was really narrow when I was doing the probing. And because of the tooth, it was the last and a lot of pressure from the partial, and also with all the fact that the patient was a really heavy boxer, I was pretty confident that it was a root fracture. So root explorative surgery, the worst if you do that minute flap is just say, well, I don't see anything, and then you close and that's it. So it doesn't take much time, and then you know a bit more.
Oh, I mean, I wasn't expecting that small. I mean, that's tiny. That's the mini flap. That one is tiny. So yeah, that's pretty quick.
Yeah, it's
That's
just
pretty
doing
quick.
that takes what?
Yeah,
Take 5 minutes?
yeah, if that. Yeah,
Well,
absolutely.
it's set up of the surgical room because I always want to have my dental assistant when I do this, have all this stuff ready because I'm already prepared to do the exo-rich preservation in that case and do the bone graft. But that's how I work. So there you go. So treatment during COVID, it's pretty much the same. You want to do the screening and review over the phone. You're going to do the treatment depending on the etiology. If there is signs and symptoms of infection for acute case or patients who are at risk, you may consider giving antibiotics. If the etiology is iatrogenic or trauma, try to keep the tooth if it's restorable. If the PERIO prognosis is favorable, you want to proceed to the endo treatment first. If the PERIO prognosis is poor, then go ahead with tooth extraction with atraumatic tooth extraction principles, trying to minimize as much as you can aerosol, and go with the latest CDO guidelines. Okay, so that's our next topic is necrotizing periodontal diseases. So Ashley, would you know what this is?
I knew this was gonna. I knew you were gonna ask me, and I was like, "Wow, it's really cool colors." And
you can say just cool.
I don't know, some like flagella stuff.
Yeah, that's about it. It's spirochetes.
Yes,
So,
that was spirochetes.
yeah,
Spirochetes.
that's what you said. That's what I heard. Okay. So necrotizing periodontal diseases, before they were called ulcerative. So the latest in the latest PERIO classification that we got rid of ulcerative because ulcerative was considered to be secondary to necrosis. Things always change, so now you just call necrotizing periodontal diseases. So instead of having a nug or a pin, oh, sorry, I switched the letters. It's with the French thing. But yeah, you just have necrotizing gingivitis, necrotizing periodontitis, or necrotizing stomatitis, or you can just say necrotizing periodontal diseases, because they represent different stages of the same disease. So, have you ever seen one case in your career, Ashley, of necrotizing period disease?
I'll be honest, because I probably have, and I didn't diagnose it correctly.
Yeah, it's not that common.
And I just remember a patient, and when I was in Belgium, I got the bill from a periodontist in the UK, and the diagnosis was ANUG. But I never. That's the only time. And then when I went to see the patient, I was kind of like, maybe it was just like you didn't brush your teeth enough.
Yeah,
perhaps.
it can be like it's very not common. I've seen, from what I can recall, 2 or 3 cases, and it was in Valcartier. You know, those young soldiers that are really, really stressed, and like when they show up, you smell it. It's really unique. So etiologically, how it works for necrotizing periodontal diseases is that there is a presence of an ulcer within the epithelium and surrounding the connective tissue. So in perio, we learn the 4 zones of necrotizing periodontal diseases, and it's important to understand that when you do the treatment, because there's the first, like the superficial zone, where everything is kind of more necrotic. Then underneath there's the neutrophil, so really your immune system trying to keep up with that. Then another, the superficial area is really just plaque and, well, biofilm, all those bacteria. Then the neutrophil rich zone, then the necrotic zone, and then underneath there is the spirochetal infiltration zone. So you don't want to go deep into that zone because there's a lot of spirochetes there. So that's how, and you're going to see how we approach this, because we really want to initially just go zone, like address the first and second zone and remove the necrotic tissue. But you don't want to go in at the beginning and really go too deep. So etiology and risk factors, it's an infection condition. So the microbiology, there's some spherochetes bacteria, but there's also tons of other bacteria. Prevotella and intermediate is kind of the bonder of all like biofilm and perio diseases, but you've got other species of other bacteria. In general, for those conditions, the host immune response is altered. So the patient is really tired or stressed, and there is a lot of, or has an immune condition that's predisposing him. And we're going to see those predisposing factors. So someone who has HIV or AIDS is at high risk. Other systemic conditions that's affecting the immune system, someone who's not eating well or who is really stressed, doesn't get enough sleep or has a lot of anxiety, someone who has a lot inadequate oral hygiene, often pre-existing gingivitis or a history of necrotizing periodontal diseases. Someone who's smoking, that's a big one. Often they'll be smoking, they'll be taking alcohol. Let's see, I'm not sure. Sometimes, in general, patients are young. Ethnicity, there's some variations there. There can be other factors such as ortho treatment, all those brackets and all like the, I don't remember all it's called, or the grills or the things like the fake gums or fake teeth that you can place, all those things that are gonna gather plaque along with all the other predisposing factors, then you've got the perfect suit to get a necrotizing periodontal disease. So we see that typically on young soldiers, especially like when they're in Saint Jean, when they're really stressed or in their field, they don't brush their teeth, they're anxious, they smoke. That's the perfect combination. There's some, like, it's really more anecdotal in the perio literatures, but in previous world wars, they were saying that there were more cases of necrotizing periodontal diseases. If you haven't seen this movie, 1917, I'm not sure if you've seen it, Ashley, it's really, really good, and geez, it's totally understandable when people are dealing with all those difficult conditions, why they would have more necrotizing periodontal diseases.
Yeah, I've often heard it related to those types of trench warfare, but you know, what really was crossing my mind is that in the next few years, if coronavirus has any effect on the oral tissues, like somebody who's gone through a bout of it.
Yeah, honestly, I wouldn't be surprised that like people would see more necrotizing periodontal diseases right now, especially with the stress, and if those who are like not coping well with the situation right now are probably more at risk, because a lot of our patients might not be brushing their teeth and totally forgetting about, like, when patients are really stressed or having depression, and we see that always in our perio patients or PTSD, one of the first things they forget is to brush their teeth and do their oral, like, normal hygiene routine for their body. So with all that, if they don't eat well and smoke on top and they're young, well, I would be surprised that people in death see more of those cases. So what are the clinical features? It's very, very, very painful. When you see some patients like that, like they have issue eating. It's so painful. And you see the statistics here. So almost close to 100%. And it's a sudden onset. It was okay, and then suddenly it's not okay. There's gingival bleeding. So if you try to probe, and like those cases, you barely want to touch the gums because it's super painful. But if you take a probe to just see if it bleeds, everything is going to bleed. The papilla, you see it well, are necrosed for most, like 94 to 100%. So it's almost all cases. And ulceration of the gingival interdental papilla. So yeah, like those cases here, you see it well. You're going to see it here. It's generally more the anteriors that you're going to see that. And the halitosis, that fetid odor, like it's really, really smelly. And that smell, you're going to remember it because when you smell it, it's very, very intense. You can see also some pseudomembrane formation. So we don't see it well here, but maybe just here. So you can see a little membrane that's going to lift. The patient will be like often there can be systemic components. So adenopathies can be present to almost half of the patients, and then a third of the patient can have a fever. So it's very acute. The necrotizing periodontal disease should be based on the history and clinical findings, getting like the predisposing factors and making sure to have like a very good clinical exam. But remember, it's super painful, so you need to be very, very gentle. You can have also necrotizing periodontitis. In addition to the gingivitis, you're going to see periodontal attachment and bone destruction, and more frequent signs of extraoral signs. You can see some bone sequestrum, and then the stomatitis is really bone denudation extended through the alveolar mucosa, and you can have very large bone sequestrum. I've never seen any stomatitis, and I think I might have seen one case of periodontitis, but it was more healed. So it's really rare. So aim of the treatment is really to alleviate the acute inflammation, reduce the microbial load, remove that necrotic tissue. The treatment, you want to treat the underlying chronic disease. So, the acute involvement, but trying to see what's the issue. What like the predisposing factors needs to be treated as well. You need to also go and try to find a way to alleviate the generalized symptoms. Give Tylenol if the patient has fever and malaise. You really want to try to correct the systemic conditions. If you don't find anything, sometimes having a CBC to know if there's any other systemic condition that is happening there, it's important, or just refer to our medical colleagues. So that's the way it's classified in the new PERIO classification. So here it says it's either like in patients who are severely compromised patients, let's say with AIDS, or like severe malnourishment. It's more common like in Africa, or geez, sorry, I'm missing sometimes. Okay, and yes, here the other portion, if it's a patient who has temporally or moderately compromised, so patient with the gingivitis that was there, and is just too stressed and smoking and habits. So it's easier to correct when the patient has that. You give them some time to be home, they need to be like off work for until the condition is healed. The aim of the treatment, we discussed it. So treatment sequence, you want to go in sequence. So the day one is to do a comprehensive medical history. Then you really want to do probing, like if you can, but the goal is really just to reduce the microbial load and remove the necrotic tissue. So on that day one, that's what you want to do. But at that time, it's really important to do that really good history to start. Then you can add some topical anesthetic, leave it for 2 to 3 minutes, before you, like, if it's too sensitive, you can just take a gentle cotton pellet, moisten, and then try to go and remove all the biofilm on the teeth. Try to remove the pseudomembranes if they're there, and the necrotic tissue. But that's just day one. If there's any superficial calculus, because sometimes you're going to see that on a patient who has a awful oral hygiene and tons of supragingival calculus, you can go ahead and remove it, but it's important for the hygienist or the dentist who does it to not avoid touching too much the gums because of the pain. Patient instructions are super important. Avoid tobacco and alcohol. Rinse daily with twice with chlorhexidine. Then rest. Toothbrushing is really just on the tooth surface and very gentle. You can give a post-op toothbrush just to have something that's very soft. Giving some analgesics, NSAIDs, Tylenol. Patients who have systemic clinical signs are on antibiotic treatment, and I have that later on in the end memoir. Oh, it's right here actually. So a good one to give is metronidazole and amoxicillin in combination. But I've got all that in the end memoir, so you'll see that later. So that was the first day, day one. Then the easy way to remember it is that you want to do double. So the first day you see it, and then you can do like the second visit either at day 2 or 3. In general, you double. So I would do day 1 and then day 3. So 1 or 2 days after the first visit, you want to see if the patient condition is improved. The pain should be reduced or no longer be present, and then at that time it's okay to do some scaling, and depending of the symptoms of the patients. Instructions to the patients are the same than the one we gave previously. Then you do a third visit. So now you're 4 to 5 days after the second visit. So I would do, okay, at day 1 and then at day 3, and then you double, so 4 days after the second visit. Essentially, at that time, the patient should be symptom-free. You still want to advise them on good oral hygiene now and talk about nutrition is key. If the patient wasn't eating properly, it needs to be eating properly, need to stop smoking. And then rinse can be maintained for another 2 to 3 weeks. Root scaling and root planing then can be repeated, or the patient can be reevaluated at 1 month. So during COVID, how do we do this? Well, you want to do the same thing, screening and review over the phone, prescribe antibiotics if the patient is at risk. I would. Scaling and root planing with hand instruments instead. Don't go with Cavitron or Piezo. And the second and third follow-up could be done just by phone if the patient is feeling fine. But you could see them as well in the clinic, depending on the latest CDO guidelines. Other considerations, healing, often with the time, like those lost papilla, they might be gone after. Sometimes it's going to heal with some shelf-like gingival margins, and it can accumulate plaque. So we can do some perioplastic procedure just to reshape a bit the gingiva. Rebuilding those papillas is very difficult, but we can try to see if there's something that can be done with the periodontist. So that's one case here. You can see a bit more of the pseudomembrane here and here and here. And you can see here the shelf, like what we were talking about. So you see how it's healing. The contour is altered, so we could do a little plasty there or remove some gingival tissue very gently just to give a better aesthetic contour. But we really need to make sure first that the healing is completely done. I wouldn't do any plastic procedure until the patient has everything under control and has a good oral hygiene. If the condition persists, it's important to think about differential diagnosis, rule out other diseases that might resemble to necrotizing periodontitis, such as desquamative gingivitis with all the pathology possible diagnosis. You also want to underlie any systemic disease causing immunosuppression. You might want to do HIV testing and consult the medical officer to discuss that. If it still persists, sometimes it's just that the patient, like the debridement that was done, wasn't that done correctly. So you need to make sure that this root planing was well done, or is not compliant. Still stressed, still not eating well, still smoking, still has or a bad oral hygiene. So that's like a more another table with different options for differential diagnosis. And we're now to the last one. Are you still there, Ashley?
Yeah, absolutely. I was just thinking about how, you know, it's a great topic to discuss a lot of these things because we talk about perio abscess, but you know, we'll see them here and here. But I'll tell you, the last time I've talked about necrotizing ulcerative periodontitis was a long time ago. So it's a great review.
Okay, I'm glad to hear that. Can you hear as well what's going on at home? Like they started doing the sidewalk in front of my office right now. So
I cannot hear your kids screaming in agony during school, and I hope you can't hear mine.
Oh, okay, cool. Yeah, no, we delayed homeschooling today, so that's good. It's an easy morning today. So next topic is primary herpetic gingivostomatitis, because we can see that it's not a typical perio disease, but it's acute and it touches the periodontal diseases, so that's why it's included here. So yes, that neat image here is herpes virus. So it's important to remember that there's a herpes family, so it's large viruses, so there's tons of different herpes viruses. I'm not gonna go through all the details. I did while I was on postgrad big research about viruses and periodontal diseases, so yeah, I won't cover that today, but that's kind of how how that herpes virus is done with all the proteins and the DNA and everything. This is just something, it's in French, but it's to show you like all the herpes viruses. What we're going to talk today is really just herpes simplex virus 1. So there is the 2 that is more touches the genital portions, but remember that Epstein-Barr's and Kaposi and all those are all also in the herpes family. And anyway, I won't cover too much that. Okay, so primary herpetic gingivostomatitis. It typically occurs in children, right? But it can happen in adults. Have you seen any cases on adults, Ashley?
Never. And I've often wondered if my kids have gotten it, but I've never seen the primary version.
Really? Okay. I guess a lot of stuff happened in Valcartier because I remember seeing one. And I saw one, and then I saw a couple of buddies in this group. So I don't know what they were doing, but anyway.
No comment.
No comment. Yeah, but he was in so much pain. That was incredible, and that's exactly how, well, that's a picture of a kid. I didn't take any picture at that time. I should, but you know, when people are in really much pain, I always feel kind of strange to go up and take the camera to capture that. Anyway.
You know, I just want to make a comment here because you've mentioned this a couple times. You know, with your iPhone now, you throw it on 4K video because I find it cumbersome to grab a camera at that second, at that moment.
Yeah.
But you got your iPhone like probably attached to your hip. They take amazing pictures right now. And if you take some video, you change your settings to 4K, 60 frames per second, and then you can, you take a quick video like a minute, and then you have a whole bunch of different pictures you can just, screen capture from.
Oh, that's a good idea. Yeah, it's just as long the patient consents, right? But yeah. So anyway, this condition typically lasts from 5 to 7 day course, up to 2 weeks for severe cases. It usually heals without scarring. And yes, you can have herpes labialis or intraoral recurrent herpetic lesions. That can be precipitated by different stimuli, such as dental appointments. And that's something that we can deal with. I'm going to cover that quickly after, even if it's not an acute condition. So primary herpetic gingival stomatitis, that's how it can look on an adult. It looks a bit like a necrotizing periodontal disease, so it's important to make the difference between the two. The clinical features, it's an abrupt onset as well, but systemic signs there are really present. So you can have cervical lymphadenopathy, chills, fever, nausea, anorexia. People have a lot of issue eating, sore mouth, and then you're going to see all those numerous pinhead vesicles everywhere in the mouth. They can rapidly collapse, such as what we can see here on the gum. And you're going to see a central ulceration covered by fibrin. So the yellow that you see is just the fibrin on top. So it can be either on the movable or attached oral mucosa. And on the gingiva, it's enlarged, painful, and very red, extremely erythematous. And you're going to see punch-out erosions along the free gingival margin. So it's different in the clinical presentation than necrotizing periodontitis, and it's important to make the difference between the two because the treatment will be very different. And on adults, you're more likely to see pharyngotonsillitis. Sorry, it's very difficult for me to say in English, but that sore throat. I remember the case I've seen, and I remember very well that patient. He had a lot of issue eating, and he had that tonsillitis. Yeah. So treatments, an early diagnosis and immediate initiation of antiviral therapy should be done. And this is new because I remember when I did dental school a long time ago, we were just waiting for the symptoms to go away. But now what we want to do is within the 3 days of onset, we want to initiate that antiviral therapy, and it's very beneficial. So you've got here the prescription. So in a cyclovir suspension in the rinse and swallow technique 5 times a day, and here's the dose for kids, for those who work in private practice. You want to also do palliative care, so NSAIDs, oh sorry, it's in French again, to reduce the pain and fever. You can give a palliative mouthwash. You can give also some lidocaine viscous just before the meals, just for adults, so it's going to numb a bit before they eat, and it's going to be easier for them to get better because it's very difficult for them to eat properly. The dental and periodontal treatment should be postponed until all acute symptoms are completed. And it's contagious at certain stage, so it's important to inform your patient and about that contagious portion. So that's a magic mouthwash recipe. Sometimes the pharmacy doesn't necessarily know when you ask for a magic mouthwash. So it's there. It's also in the aide-mémoire. And then I just wanted to add the treatment for herpes labialis. I know it's not acute, but often it can be, a lot of our patients will mention that to us, and Valtrex is super efficient to deal with herpes labialis. So I wrote the dose here. And you can give it prophylactic because some patients will say, every time I go to the dentist, I get that big herpes lesion. So you can give Valtrex 2,000 milligrams twice, one day before at day one, the day of the dental appointment, and then the second day for another 1,000 milligrams twice a day. And it can be very helpful. Maybe they're still going to have one, but it's not going to be as big and as annoying. Dental and periodontal treatment should always be postponed until acute symptoms are subsided to avoid the possibility of exacerbation or contagions. So really in that initial phase where you see like it's really the first 2-3 days, let's say, of the herpes labialis with all the vesicles, that's really when you don't want to treat the patients and just postpone dental appointment.
You know, that's a really good point, because I remember I saw one patient, I don't know how long ago it was, and that was one of his concerns. It's like, I'm always going to break out with a cold sore afterwards. And I was like, oh, and now I'm thinking, you know, that's an option I'd never even thought of, giving it sort of prophylactically.
Yeah, and it works well. I've done it a couple of times and the patient really appreciated it, because I remember seeing them right after with all the cold sores, and sometimes it can be really big for them. Key points during COVID, well, it's pretty much the same. Screening, review history over the phone, no changes to the treatment we discussed, and just make sure that you do a proper follow-up until the resolution of the symptoms. Here is something that I found that I had in the PERIO literature. It's old, it's 2004, but it shows the difference between necrotizing gingivitis and then acute herpetic gingivostomatitis. So you see the difference here. The site of the ulcers will be different. The way the ulcers are also different. So in an herpetic lesion, there's going to be vesicles, versus for a necrotizing condition, it's just punched out, yellow, white, bleed spontaneously and very painful on stimulation. On herpetic lesions, the gum is not especially tender and won't bleed as much. The fever is very more predominant for herpetic gingivostomatitis, and the symptoms, like here they say, like, I don't know about that, but the deep dead feeling teeth for necrotizing gingivitis versus acute herpetic gingivostomatitis, the patient will more complain of sore mouth, because it's not only the gums, it's the overall tissue in general. And the duration of the ulcers will help you make that diagnosis. So the ulceration portion, if you give appropriate treatment for a necrotizing gingivitis, it's very short, 1 to 3 days, but for acute herpetic gingivostomatitis, it can be more than a week, even with treatment. So yeah, so that should help you make your diagnosis. Okay. Then, how are we doing for time, Ashley? Okay, oh geez, I'm speaking a lot.
It's all good. It's all good. It's all good.
It's all good? Okay.
Yeah, absolutely. It's really pertinent, great information, so just keep going.
Okay. Now my next portion is postoperative care during COVID. It's very short because that was for me a big concern initially when I was thinking about COVID in March and thinking about all the perio surgery I did, and I wanted to make sure of like all the suture would be out, and then I wouldn't have any infections of all my GDR cases. And anyway, it's not that urgent now, but I think it's still important to cover. It's going to be useful for when we get back to more normal dental treatments. But the key points during COVID, if a patient with perio condition has had a perio surgery and there's an issue, well, contact the treating periodontist. That's the first thing to do, because we know our patients, and there should be very few now. In the second week of COVID, I contacted we deal with some referrals in private practice. I contacted all the periodontists to see how they were doing their post-op of all the patients, and they were doing them all and taking care of all the sutures removal and everything. So at this point, there shouldn't be a lot of those cases. But anyway, I just wanted to discuss a bit about this still. So sutures during COVID. Let's say you see a patient who had a perio surgery and there's still sutures in place. Well, the first thing to do is try to find what type, well, first contact the treating periodontist, and then what type of suture was used. Because if it's resorbable, it's going to resorb, but some resorbable sutures, like the polyglactin, will last for a very long time, but it's okay to leave it in place. However, when the sutures normally are still there, there's normally a reason why we leave them that longer. If there is non-resorbable sutures, then contact the periodontist, because we really want to know why there's still non-resorbable sutures in place. So here I wrote you like the short-term, long-term resorbable sutures. So you've got that as an aide-mémoire if you're unsure about which suture is which. The non-resorbable sutures, for me, I use a lot of PTFE sutures and a lot of polypropylene sutures. So for PTFE sutures, it's white. For polypropylene, it's blue, but some periodontists will use nylon, silk, polyethylene, polyester. So there's very multiple types. It's very just important to know which type of suture was used. And then knowing, like in reading the chart, it's always written there. And oh, the other thing that I want to say, I had a little something that I did here. Oh, here it is. So let's say you would need to remove one of my suture. It's also important to know, yes, which type of suture, but also which technique. Let's say you're in Kingston, Trenton, and seeing some of my patients, and I've done a CTG. Well, for CTG, connective tissue graft, I do very, very special sutures. The way I think there's 6 places where I enter with that needle, just to make sure I hold my graft as I want. So please don't remove the sutures unless you contacted me. And the good way to remember, if you're ever going to remove a suture that is non-resorbable, this is a floss, but it looks a lot like PTFE suture. Can you see it, Ashley?
Yes, ma'am.
Okay, cool. So often when we do non-resorbable suture, with time and inflammation and healing, you won't see much and you'll just see those little braids. I always leave my non-resorbable sutures, the braids, it's braids, eh? Sorry, I've been speaking in English in a long time, very long, so they're easy to find. So when you don't find the knot, you really want to, sometimes I'll put some topical anesthetic, and then I really pull until I see the knot. Because sometimes you won't see the knot. And see, I've just broken my PTFE suture here. But you really want to make sure that you pull on the knot, and then when you pull on the knot, you find those 2 braids, and then what you'll do with your scissors, and you cut here, and then you're gonna pull on the knot and then pull everything out. Never, never, never just go in and you don't see anything and then you cut this, because you're gonna leave tons of non-resorbable suture in the tissue, and then this can lead to a post-op infection. So I would just advise contact the periodontist, make sure that you know what type of suture he's using. If it's a horizontal mattress suture, it's going to show in the chart. If it's a suspended, anyway, just something to be careful with when you remove sutures. Okay, I'm done with sutures. Okay, post-op infection after perio surgery, review the dental chart and contact the treating periodontist. Remember, in general, incidence of post-op infection after perio surgery is approximately 1%. So it's really low. And I've got 1 clinical cases for you, Ashley.
Awesome.
So can you tell me what you think of this picture?
Oh my gosh, I'm on my oral boards again. I mean, okay, so what do I see? I see we've got like a maxillary arch, and we're looking from the palate.
Yeah,
Looks like
the palate here. Good.
Yeah, it looks like we've got tooth number I don't know if I'm looking for, I don't know. So
That's
like,
2.3, 2.4, then 2.6, 2.7, or 2.7,
yeah,
2.8, something like that.
yeah, so 2.6, well, I guess we're missing the 5 and
The 6, yeah.
the 6. Okay, so 5 and 6 are gone. Maybe
Yeah.
there was a recent extraction or some sort of trauma, one or the other.
I did an APF here.
What's that?
I did an APF, apically position flap,
Yep.
PERIO surgery here. And that's the way the patient showed up week 1 after the surgery. What do you think?
I don't know. In my hands, that would be normal, but apparently because you're showing it, it's not normal.
Well, yeah, I actually agree with you. It's just like, for me, it's just like, nah, it's just necrosis here. It's very painful for the patient
Yep.
because when we do APF, and I'm going to show you the next picture. Okay, that's how the patient presented. So you see that, like how much gum he had, and he had like tons of calculus, heavy smoker, wouldn't show up to most of his appointments, terrible, like compliant patient. He had as well a partial, so a maxillary PUD. Oh, oops. Yeah, but you see here, this was flapping like this and taking the shape of his PUD. The picture doesn't show well, but you can see that PUD there. That was really, really thick. When I did the APF, I did like all this and all this. And then I removed that like flubby things up front. It looked like a butterfly. And then the APF on that sextant from here, so it would come here, here, and here, and then do a kind of a distal wedge, but it's just like a very, like, I took out all this, and then you see like the incision line. Oh yeah, I started just on the tree. I think I did that the next appointment because it was a very big appointment for him. Very painful too after, but not during. It's never painful during.
Never.
But yeah, so you see here an incisional, then crestal incision, another crestal incision, then is sulcular incision, sulcular incision. I think I might have done a distal wedge at the back there too. But you see like all the thickness of the tissue. When we do an APF, an apically position flap, we really want to make sure that we recreate a normal as we can, bony and gingival architecture. So you have to really make the tissue thin. You really don't want to have, you see how thin it was here? It was perfect. So about like 1.5 millimeters. So you really want to make it thin, and all the rest you remove all that extra tissue. And then with the bone, you really want to scallop and make it nice and do the fastening everywhere. And anyway, that's not the point of the lecture. You see all the calculus that was there still present. In this case, I normally do initial therapy always before, but in this case, I knew there was no way just doing initial therapy would be fine. So I remove all the calculus at the same time. So that's what we do really, and then you recreate the shape. But anyway, so that's some pieces I removed, all this got away. And then when you close back, you see that little thing here that was here on that side. I did some suturing. Suturing could have been a bit better, but you see how the tissue was nice and thin there. But when you remove as much tissue, it's normal sometimes that, yes, the tissue, because it's really thin, will necrose a bit at the surface. But necrosis in general, patients don't have too much pain, but sometimes, especially for him, because I removed so much, it was much more painful. But you see here, I removed a lot, and still it's growing back there a bit too high. But anyway, it healed really nicely, but it didn't show up for the couple of next appointments. So I don't have a lot of nice pictures of how it healed. Anyway, So sometimes I was just showing that to see, like, a lot of time people will say, oh, it's infected, because they see the yellow, but the yellow is just the fibrin as the healing is going on, and there's some necrosis that was there, but it's healing normally. So people often after perio surgery will say, oh, I think you've got a post-op infection, but just if you're unsure, take a picture, send it to the treating periodontist, and you'll know more. Okay, next point, recent extraction with ridge preservation. If we use in perio and as well in oral surgery, resorbable and non-resorbable membrane. So it's very important to know which type of membrane was used if you see a patient for post-op follow-up. And you really want to make sure that you monitor any signs of symptoms of infection. So during COVID, if there's a resorbable membrane and sutures that were used, you really want to just monitor to make sure there's no infection that will appear until the site is completely healed. Resorbable membranes and sutures, well, it's going to resorb, so not much to worry about. But sometimes those sites can still get infected, but you need to contact the periodontist who treated the patient if it happens. For non-resorbable membranes, and I showed you that technique, Ashley, or we discussed it, I really like using the Cytoplast DPTFE membrane. It's very, very easy to place. If normally we remove that membrane between 4 to 6 weeks after the extraction. So if for any reason there's still a membrane and you see a patient, now is the time to remove it. And I'll show you, it's super easy to remove, but you still want to contact the periodontist or the treating dentist who did the surgery. I show this technique to all the dentists who comes for mentorship with me because I find this technique really good. If there are signs of symptoms of infection, remove the non-resorbable membrane immediately, consider antibiotics, and contact the periodontist. So that's one of the cases I did while I was in university. It's not perfect, but it's pretty good. So I did the extraction here of that 1/6. You see I use a traumatic technique, split the roots, got everything out. It was really nice to see, well, like I could have maybe even tried to place an implant right away, but I think the sinus was a bit too close for that. And I don't do immediate implants on molars. I just like to take it one step at a time, but it's something that's possible. And then I did put my bone for my ridge preservation, and then, oops, that membrane, you can see here, it's really easy to place. So it's a DPTFE membranes with little holes. The goal of the little holes, they've made some studies, is really to prevent bacterial infiltration. So the holes needs to be on top while the very smooth portion needs to be underneath. You need to have 4 to 6 millimeter both sides here, and it needs to be on the bone. And when you do the exo and ridge preservation, I saw that I think Major Schmidt did a presentation on that, or you need to really make sure that you really clean well the socket and get rid of all lesions before you put the bone graft in. And then after putting the membrane, the bone, the membrane, I like to do internal matrices. Here my suture is not correctly done. I was still learning, but it's pretty good. You really just want to make sure to have a pressure, but I really like the internal horizontal mattress because it brings the flap together and put the pressure down on that membrane. And when you need to remove that 4 to 6 weeks from now, that's really easy. You remove the suture first, and then you take your pliers and you just grip, and then you pull. So it's super, super easy to remove. That's something we can teach you over the phone if you're not sure, but really there's nothing to worry about. And when it heals, that's how this case healed. What I like with this technique is that you get additional keratinized tissue from that technique where the membrane was. Sometimes, yes, you can still see some spots, but with time it's gonna all get nice, or you can see that line where the membrane was, and it's gonna change with time. Just be patient. And then that was the day I wanted to place my implant, the bone. I actually had too much bone here, so I had to remove some bone before I placed my implant, which is always a good problem to have too much bone, and I rather do have too much bone than not enough, so that's why I always do a rich preservation. And that's the implant I placed here. You can see the tooth is a bit shifted, so we needed to take that into consideration with our prosthodontist and our wax up to make sure the position of the implant is exactly where the prosthodontist and the general dentist was placing the crown on the implant. Okay, finally, if there's my last thing about surgeries, if there was any recent guided bone regeneration, so GBR. So this is when we were rebuilding the bone before we were placing an implant in general. You really want to contact the treating periodontist if there's an issue with that site. For resorbable membranes, no treatment is needed. Post-op instructions, monitor signs and symptoms during COVID by phone until this site is completely healed. If there is non-resorbable membranes with pins and screws, and if there are signs of infection or the non-resorbable membrane or the pins or screws are getting exposed, you need to contact the treating periodontist or oral surgeons as soon as possible for guidance. That's very important. For me, I think I do have still 4 patients with non-resorbable membranes that are in place. I like to follow up with them once in a while to make sure everything is good. I don't do those cases very often, and I really pick the patients correctly because those cases can really infect badly when we take non-resorbable membranes for big GBR cases. So that's a case I did in the university. Now I do bigger cases than this. So you can see that there was a horizontal bone loss here, and you can see the horizontal bone deficiency. There was some vertical defect as well, or a vertical deficiency that we were able to take care of, but that was the CBCT we took and trying to place the implant. You can see that it was a 3.5 implant, I think. You can see there's not sufficient bone. We want to have normally 2 millimeters from both sides of the implant, and I really like to have that minimum. So we couldn't place that implant without doing a GBR. Sometimes people will place an implant and do the GBR at the same time. It depends. In this case, I wanted to do it and stage it, and I thought it was better this way. You can see here, like the defect was pretty important. So this is how we dealt with that. We took some autogenous bone on the chin with a bone scraper, mix it with BioWAS 50-50%. This is not a procedure that's easy to do, not something you want to start doing in your practice. Placing those screws placing those screws, sometimes it works super well. You need to be careful of the root position. And there's 1 or 2, I think there's only 1 there on the lingual side, but placing the screw on the lingual side, it's tricky. Sometimes the bone density will make it complex to make sure the screws hold well in place. And the trimming of that membrane is super important. So that's a reinforced titanium PTFE membrane. And now we want to leave that, close the site, and I left it for 8 months. That's my typical 8 months, and 8 months is really just a minimum with that technique. And here you can see what happened with this, especially on the intermandibular side area. The gingival tissue and mucosa is really thin, so sometimes you can get a membrane exposure. We're never really too happy to see a membrane exposure because that can lead to an infection and then start losing all the bone graft underneath. However, it happened only just before we went in for the surgery for the implant at 8 months, so it was okay. We can do some babysitting of the membrane, but babysitting of the membrane means that we clean that membrane almost on a weekly or bi-weekly intervals, and I like to do it that myself so I can quickly see if there is a sign of infection arriving, because if there's an infection, then what we want to do is open the flap and remove that membrane and all those screws. So that's really something that the periodontists or the oral surgeons will do, and we need to be informed if you start seeing this. Okay, and that's finally that GBR cases. So you can see all very nice bone, really hard, no issues placing the implant. You can see the bone volume that we got from that GBR, and we were able to place the implant right here, exactly where we wanted. Patient was happy. It went really well. So that's the GBR case. So that's what we can do as well for you when eventually we'll be able to place implants once again. Finally, that's the aide-mémoire I talked to you about. It's also on that document that we sent you. So you've got all the medication for like antibiotics, for acute perio abscesses, for necrotizing periodontal diseases, for odontogenic or post-op infection. If there is a patient that has an issue, or for prophylactics and biotherapy, we've got everything there. If there is allergy and everything, all the choices. I've got as well here the antiviral therapy, antifungal. If you've got some conditions that are infected with on top, it's always good to remember that. Then analgesic. In the latest literature, it was safe to use NSAIDs, so that came from Health Canada website, but you don't want to do that long term, it's just short term. You've got opioids here, that's what I like to use. I'm very careful. In general, I just deal for pain with my patients, even for big GBR cases. I just do ibuprofen in combination with acetaminophen, and 95% of my patients are fine with that. I think I had one in 2 years that needed opioids, and then some anxiolytics, and that's pretty much it. So finally, oh, this is François. François, on est à la caméra. Hello. I want to say thank you for your attention. I'm not sure, Ashley, if you had more questions for me.
No, actually, it was like an incredible presentation, and really there's one point we can talk about it offline, but I actually want to include it here, is because I think that, you know, we're talking about COVID, we're talking about extractions, we're talking about perio issues, and one of the things that we pride ourselves in the military of is mentoring.
Yeah.
And I think one of the ways we can do this is actually is maybe down the road we could look towards, because you really sold me on this non-resorbable membrane kind of issue. Yeah. I don't know why you sold me on it, but it's actually useful. It's easy to put in.
Yeah.
And the dental assistant likes it. It's easier to, everything's easier about it. So maybe we could look at down the road creating like a mentoring kind of just like a webinar about that, yeah, about how to simply do it. Because what we're doing is our frontline our dentists are doing extractions, and to properly preserve it might be a useful technique.
Yeah, I would love to do exo-enriched preservation technique. I know Devin did a pretty neat lecture on that, but to talk about really the rich preservation options,
yeah,
because you really need to know why you're doing it, and like the choice of bone, the choice of membrane. There is a lot of rationale before doing something. So it's really important to not just throw something and then go back later and place an implant. It's really important to know why we do things, and I would love to do that at some point, but yeah, who knows. For mentorship, that would be useful as well, because we'll see what happens with COVID, but there might be less money to travel for mentorship. I'm not sure, but yeah, we could do something. Yeah.
Yeah, absolutely. So thank you so much for an incredible lecture, and we're going to
Yeah.
get this posted up soon. And then what we'll do is any questions, I know that you're fully available. So what we'll do is we'll have the PDF ready for download. And then, you know, if people need to get a hold of you, they can email me or email you direct to the D1 and then go from there.
Yeah, cool. And I wanted to show people like and say that it's very important during COVID to keep up with your hobbies and families. And so I've been doing a lot of gardening, and lately with my family in the backyard. My husband's helping me there. You see, he even has the T-shirt "Gum Guy" on. So he's not very busy right now. Some of you might have known him from the military, but you know, our colleagues in private practice at some point will start working again. But for now, he's doing a lot of gardening stuff with me, and I think he's getting a bit tired of that gardening stuff. But anyway, look at it's nice stuff. Like periodontists can do a lot of stuff. Uh, and my personal hobby for this summer is, you see a C1 here. So my goal by the end of the summer is try to stay afloat and not flip, because that's an Olympic canoe, and I love paddling. So whatever you do, remember to do that. And yeah, it's good for your mental health.
Yeah, absolutely. Thank you so much, Sophie.
Okay, you're welcome, Ashley. And we'll chat soon, I guess.
Yeah, hold on. I'm just going to stop recording here.
Okay.